Good afternoon. My name's Andrew Zannettino. I'd like to welcome you all to the third Adelaide Biomed City Mini-Review webinar series. Since its commenced in its early life, it's seen an increase in participants from 50 to 100 in the second mini-review that was last week. That's a growth of 100%, if my math serves me correct. As you would be aware, these mini-reviews were really established to increase the awareness of many of the many and varied research capabilities and activities within the ABMC precinct amongst researchers, clinicians and industry. And before I introduce our first speaker, I'd like to acknowledge the Kaurna people, the original custodians on the land on which we meet here today, and I pay my respects to elders past, present and future. I'd also like to remind you that you can use the Q&A section of your Zoom window, and that will allow me to relate any of your questions to the speaker. So that allows me to move on to our first speaker for this afternoon. That is Professor Tracy Merlin. Tracy is the interim head of the School of Public Health at the University of Adelaide. She is a clinical epidemiologist and the creator and director of a research group called ARTA, which she will talk about today. She is the incoming board chair of the International Network of Agencies for Health Technology Assessment, which is a network of 51 government and not-for-profit agencies that provide evidence to policymakers in 30 countries. The title of her presentation this afternoon is Health for All, research that shaped public access to medicines, tests, devices and procedures. Thank you, Tracy.
Thank you, Andrew. That was a heck of a mouthful and you got through it. That's great. Hopefully everybody can see my screen. If not, please, Andrew, sing out. So I think the first thing I need to say is that public health isn't just about COVID-19, although I suspect that you'd be forgiven for thinking that at the moment with the amount of things that are going on. But public health is multidisciplinary. We cover a lot of ground. We have the central goal is to maximise health at the population level. We're concerned with health for all, no matter what background or your socioeconomic status. We can look at the whole of the of healthcare and how well it functions. We're about making a difference, so we try and come up with solutions or strategies to implement health education, health promotion, monitor health, make suggestions for changes to laws and policies, administering health services better, and conducting research. These last two bits are what I'm interested in, what I do. So my work is health technology assessment, and we look at the value of a health technology at different points in its life cycle. And we do this to inform decision makers, or particularly policy makers, so that they can decide what should come into the health system, what needs to go out, and try and make the health system a bit more equitable, efficient, and hopefully high quality. So what's a health technology? It tends to confuse people, but it's really any sort of health intervention. We look at drugs, we look at surgical procedures, we look at gene sequencing, breast implants, vaccination, all sorts of blood tests. And we could look at leeches. I actually haven't looked at this one yet, but in 2005, the US Food and Drug Administration listed leeches as medical devices for use in plastic surgery. So I'll be waiting for that one with bated breath. Anyway, health technology comes into the health system. Someone has a bright idea here. It's trialled in clinical trials. It goes through the regulatory process to get market approval so it can come into the health system. The company or the drug company or whatever will invariably try and get government subsidy for it through our various national insurance schemes. And that allows greater access to the population, and then it's taken up in clinical practice, used optimally, we hope. And then if invariably what happens is another technology comes in that's as good or better, and then the original one is disinvested. And health technology assessment looks at that health technology and reassesses it at each of these different points in time. So my group, ARTA, Adelaide Health Technology Assessment, informs health decisions with high quality evidence. We do predominantly secondary research, so we look at the research that's already been done and try and pull it all together and make sense of it and make suggestions to policymakers about what to do with it. But we also do some primary research trials, studies to look at health interventions as well. This is my team. On our colour days, we have every 2 months or so, we all dress in the same colour, raise some money for charity and have some food as well. They're a terrific group and very dedicated. But it wasn't that big to start with. We started in 2001. The people that we have are a mix. As I said, public health is multidisciplinary, so we have a whole range of people who help us evaluate these health technologies. We have a couple of refugees from the bench science, economists, pharmacists, clinical epidemiologists like myself, statisticians. In 2007, we were trademarked and had a business name, and that was largely because we bring in a lot of money through our contract research. Our current clients are federal government, so the Technology Assessment and Access Division primarily. We also provide research to World Health Organization, Singapore Ministry of Health. We do clinical practice guidelines for the NHMRC, and we do regulatory assessments for Therapeutic Goods Administration, or the TGA. We start off with a question from a decision maker. They want to know if the technology should be available or used, whether it should be funded or whether it should be removed. And then they contract us to look at it. And we'll look at the clinical need for the technology first. You know, is there a patient population group that needs it? We try and work out how the technology would be used in clinical practice in the health system. What sort of pathway, where it would fit in the pathway of care, what setting it would be used in, and what patient groups. We'll look at what sort of technologies it will replace or supplement, because there's things already being used in the health system. And the comparator is really important. So if you are, an example, on the COVID theme, we've got a number of vaccines in human trials at the moment. This came from WHO in July. It's probably a few more since then. And so when we get our first vaccine, it will be compared to no vaccination, no use of immunisation, and be looking at the impact of with the vaccine and without the vaccine. But once we get a vaccine, there'll be others coming, and then we'll be looking at comparing those other vaccines. Is it as safe as the other ones? Is it as effective? Is it as cost effective? Is it even better? The comparator is really important. We also look at who will deliver the technology. Is additional training required? That's particularly important for surgical procedures because there's a learning curve associated with them. We're really interested in what the patient relevant benefits and harms are of the technology, and we'll do a systematic review of the literature to have a look at that. But it won't just be published literature. We get dossiers of information from the companies, from the drug companies, or the people providing the technology, and we look at that quite closely. We look at, does it work better in some groups than others? Should it be delivered one way rather than another? What's the sequencing of care? We do economic modelling to see whether the technology is good value for money. We model the clinical effects and the costs. And then we look at how the technology should be implemented into the health system. So we'll look at ethical issues associated with it, access issues, consumer preferences, impact on workforce. So you can see why we have so many disciplines involved, because we look at the technology with a very wide lens. This is the HTA process, federal HTA process in Australia, and going from the regulatory part with the TGA here to the different schemes for reimbursing the technologies. And this part here, evaluating medicines, we've done for the Pharmaceutical Benefits Advisory Committee since 2004. We've looked at medical services, tests, devices, consultation items and things for the Medical Services Advisory Committee since 2001. And as you can see, that's our two main health insurance schemes, PBS and Medicare, informs those decisions. We've been looking at TGA, market approval of devices and cancer drugs since 2018. And this part here, we actually created. So this was a method and a process that we developed to look at codependent technologies. And they involve like a personalised medicine where you have a companion diagnostic looking at a genetic biomarker, and then that biomarker is targeted by a cancer drug. And we look at both of those together. We're the first in the world to do that. That's written up here in this paper. So altogether, we've looked at 231 medicines on the PBS, 13, well, for a decision to fund on the PBS, they may not have got on there, 13 cancer drugs for the TGA, 145 medical device evaluations for the TGA. And those three things, I can't talk about individual cases because it's all commercial and confidence. I can, however, talk about our work for looking at medical services for funding under Medicare. We've done 59 so far. Of those, 23 of the reports resulted in a public funding decision, a positive one, and there's been 44 Medicare items introduced as a consequence, and you can see the sort of financial impact it has. These are only a selected number of those 59, but also the range of different technologies that we've looked at. We do investigator-initiated research as well. This is mostly my PhD students, research fellows. We've looked at mobile health apps, thresholds for public funding, comparing us with the UK, the impact of off-label use of antimicrobials, ethical analysis of different public funding approaches, and decision support tools as well. That's only the sort of stuff we've done in the last year. We look at any sort of things to do with health technologies and their impact on the health system. I'm involved in a couple of trials looking at the first one, the impact of genomic testing on decision making, clinical decision making. I'm working with Professor Hamish Scott on that. I'm working with Libby Ruffed, looking at pharmacist intervention in aged care. We're providing economic evaluations for both of those trials and some data collection. And we also provide support for trials where I'm not necessarily a CI on it, but because we're a methodological group and we've got IT, statisticians and economists, those things are very helpful for trials. So we provide support for those. So there you are. That's a very, very quick whistle-stop tour of the work that my group does. If you've got any questions or would like to know more, that's my email address on the screen. Thanks. I'll just stop sharing.
Thank you, Tracy. That was a fantastic presentation. Clearly, the nature of your work does lend itself to open collaboration. So, and thank you for really highlighting the fact that there is opportunities to collaborate given the expertise of your team. I have one really simple question, and that relates to the fact that you have such a diversity of items that you assess or areas that you assess. I'm just wondering how much content knowledge is actually required to make the types of assessments that you do? And if so, how do you actually garner that content expertise?
Well, in a number of ways. So we don't start off being experts in the area, that's for sure. Although we've learnt a bit over the last 20 years. We've got a pretty well-rounded knowledge of medicine. But we're methodologists, so we're looking at the literature to see what we can trust, whether the evidence that's been produced is actually trustworthy. But we do work with clinicians, and we have experts that we consult and try and get information from if we have any uncertainties. And there's, you know, a broad range of different people that we talk to and try and understand what's happening with that particular technology. But because we're looking at the evidence base there, we're looking to see how well it's been done. Do we believe in the health outcomes that have been gained? So that's, yeah, we just apply that sort of evidence-based medicine type approach across all the sorts of technologies that we look at. But I have had, you know, I remember one clinician that I was working with, one of my team had worked on that project for 2 years, and he said she had a better idea about the whole field than he did because she'd read everything to do with it in that time period. That was particularly a genetic test we were looking at. So, yeah, we don't get bored. That's for sure.
Oh, indeed, indeed.
No.
Look, thank you so much for participating in this forum. Again, it's an opportunity for presenters to actually give a clear idea of the nature and type of work that they do, and hopefully that provides opportunities for further collaboration. So again, thank you so much, Tracy, for a fantastic presentation.
Thank you.
Cheers. Gives me great pleasure to introduce our second speaker for this afternoon, and that is Professor Caroline Miller. Caroline is the Director of the Health Policy Centre based at SAMRI, and she's the Professor in the School of Public Health at the University of Adelaide. She's also an NHMRC emerging leader. They are like unicorns, very rare, but well done to you for that award. And Caroline's research is focused on interventions to reduce the preventable burdens of non-communicable diseases. She's most known for her work in tobacco control and is now applying the lessons that she's learned from tobacco control to improving the population's diet. And again, that's something that's dear to my heart. I'm always trying to improve my diet. The Health Policy Centre is also leading a COVID-19 evidence synthesis service to support South Australian and Australian policy responses to COVID-19. It gives me great pleasure to introduce you this afternoon, and the title of your presentation is SAMRI Health Policy Centre. So thanks so much, Caroline.
Thank you, and I'll just share my screen, which I'm not super experienced in, so just bear with me. How does that look?
Perfect.
All good? No feedback to the contrary? Great. Okay, so I thought I'll do just a quick overview of what we do in the Health Policy Centre. So this is a centre which is based physically at SAMRI, and it's a collaboration really between, we have SAMRI staff and we have University of Adelaide School of Public Health staff, of which I am one, and we also have students from the school, from University of Adelaide across the faculty actually. So our main focus is around primary prevention of non-communicable diseases, and the way we cover that is by looking at the behavioural and metabolic drivers of those diseases and trying to bring about behaviour change in those areas. So tobacco control, diet, obesity, alcohol are our sort of core areas of our work. One of the things that I think is a bit more unique about us is we have a very heavy orientation towards end user engagement. So we spend a lot of time interacting, as I'm sure Tracy does as well, interacting with policymakers, end users, people who are delivering programs as well. So our background and our training is in psychology and public health. I'm also trained in economics. So these are sort of the sciences of behaviour change, if you will. The work that we do is focused on population monitoring. We've got monitoring systems that have run for over 2 decades. We do research to inform policy development. We evaluate policy, and we also do evidence synthesis. What we produce, or we aim to produce, is research that's policy ready in a timely way, that's relevant and readily accessible for policymakers. And we do a lot of evidence briefing work to help policymakers do real-time decision making. So if they get a question from a minister or what have you. And ultimately, we're looking to bring about health behaviour change via policy change or population level interventions. So I'm going to run through our 3 core areas of work and a little COVID, but I'll do it really quickly. So Australia is a world leader in tobacco control, and we've worked in tobacco control I've worked in tobacco control for 25 years, I worked out, which seems like a long time. So we do work to support evidence-based interventions to bring around, to reduce smoking rates at a population level, as well as amongst core priority groups. We do that through, we're government funded in this work and have been for many years, state government funded predominantly, sometimes federal, sometimes international. Some areas where we've had impact, so we've been involved in every tobacco control intervention that you've ever heard of, but most recently we've been involved in plain packaging in both Australia, and then I consulted and helped the Singapore government become the first country in Asia at the time. So this was a world first policy intervention. It was challenged internationally, legally, and we did work that helped support and defeat those challenges, for example, at the World Trade Organization rather. Recently, we've been doing work to help inform the state government and also the Australian government position on e-cigarettes, how to manage that policy issue, which is complex as the evidence is emerging. We also do work to support interventions, so a lot of work around tobacco campaigns. We've done this for a long time, so monitoring population trends to identify need, doing work which helps people in government develop the campaigns, evaluating them, and then the result of that is quality campaigns that have demonstrated impact on smoking rates. We've done work monitoring and measuring the effectiveness of quitline services in terms of smoking cessation over long periods of time. And we've also done work that's informed intervention for priority groups. And the work that we do leads to investment and sometimes disinvestment by government. I'm particularly focused on sugary drinks. At the moment, I've got a program of NHMRC funded research in this space. So unlike tobacco control, where Australia is a world leader, sugary drinks are a space where really Australia has been a bit of, or obesity prevention really is an area where Australia's got a long way to go. So we've been doing work looking at different interventions to reduce sugary drink consumption. We've been testing different health warnings and different sugar content labels. And then the latest work that I've had funded is around, if we do become successful in driving these policy changes around sugar sweetened beverages, then what are we going to do around unintended consequences to do with perhaps artificially sweetened beverages and fruit juice, for example. In terms of impact, we've had some impact to date, but mostly we have ambition to have impact. So there's been a review of Australia's health star rating system, and the Australian and New Zealand governments are currently considering whether to put added sugar labelling on our packages. We've been successful in removing the energy only icon option, which is on the can of Coke there. We've had success collectively across the country in removing the loophole, which had given Milo 4.5 stars. And we're still work in progress on looking at the way the algorithm calculates the stars for juice, because at the moment juice, which may have as much sugar as lemonade or what have you, scores a 5-star rating and has a health halo. I've also been assisting the Singapore government, which at the moment are leading the world with a suite of policy reform around sugar sweetened beverages. So I'll just move really quickly through now. We also have a program of research around alcohol, and this is NHMRC funded and also government funded, and Jackie Bowden in my group is leading that. And I just thought I'd talk for 1 minute about the work we've been doing around COVID. We sort of brought our evidence synthesis skills and turned them towards COVID. SAMRI was asked to provide assistance to SA Health with reviewing, summarising, synthesising, contextualising research around COVID for government decision making, both for our South Australian task force, and some of the work's gone up to the AHPPC to help inform some of their decision making as well. So we brought the skills that we already had in the space, and then we bring in external input to assist us with virology or whatever the topic happens to be. at the time. And so we've seen some of the evidence syntheses that we've done influence policy making decision locally and federally around Australia's largely very successful response to COVID. So we've published all our evidence updates for people who are interested, and I'd just like to acknowledge my team and also the people that fund us. So thanks very much. Oops, and I'll stop sharing.
Unmute. Thanks, Caroline, for the great presentation. Caroline, in the absence of questions from the audience, I wanted to ask a question around the idea that the evidence synthesis approaches that you do use, they're broadly applicable, as you demonstrated, between tobacco consumption and sugary drinks. What does surprise me, though, in the context of evidence, that we still fail to adopt good measures. And I think sugar is one example where there has been World Health Organization recommendations around sugar taxes and the benefits thereof, but we've failed to adopt that approach. Can you speak to that? Why governments are reticent to adopt good measures that have had shown success?
Yeah, I think it's, you know, it's where science meets politics, really, is the short answer. And I think everything that we've achieved in tobacco control has been very hard. We take it for granted now, but it's been very hard fought. And that's because what we're trying to achieve in terms of good public health is coming up against the commercial interests of a tobacco company. And in the instance of sugar sweetened beverages, it's clearly, you know, I mean, obviously, sugary drink companies are maximising profits, and that creates, you know, but that leads to overconsumption in terms of public health. So I think, you know, coming from a background where we bring behavioural science but also bring economics, we know that what we're trying to do is influence not only the health minister but also the treasurer. I think in Australia we've been slower on sugary drinks. You know, we have sugar growing in Australia, and you know, we have a parliament at the moment where those people from those constituencies probably have a lot of influence. So I do think that the tide will turn, because the evidence around sugary drinks taxes is so overwhelmingly strong. Most of the evidence we're seeing, a lot of evidence is coming out of South American countries at the moment. And I think that what will happen is, I think obesity will, and chronic disease such as diabetes, will create such a health burden that it will reach the point where the treasurer will say enough, and that's when we'll start to see reform in Australia like we did with tobacco control.
Thank you, Caroline. I have a question from the audience, from Rachel Stevens. Has the as prepared loophole removal come into effect yet?
Yes. So, well, actually, what's happened is that it has been adopted, and Milo have, well, Nestle have taken the stars off Milo as a consequence. The Health Star rating scheme has its supporters and it has its detractors, and it's very easy to see arguments on both sides. One of the real limitations around the Health Star rating scheme is that it's voluntary. And so what public health, you know, what we argue from a public health point of view, that is that industry then game it. So when Milo can get 4.5 stars, they use 4.5 stars, and when they lose their as prepared loophole, then they don't put stars on their product at all, unfortunately. So that is definitely one of the major limitations, but public health policy progress is slow and incremental.
I have another question. Thank you so much, Caroline. I have another question. This is from Gary Whitted. To clarify the strategy regarding communication of obesity versus chronic disease message.
So what does Gary mean? He has a question to clarify strategy regarding communication of obesity versus chronic disease message. I'm not sure what you mean, Gary. I'm sorry. Do you know, what do you think, Andrew? What do you think Gary's asking?
Let's assume that it means that, is there a difference in the approach to address the issue around communicating the obesity versus the effects of obesity in terms of chronic disease management?
I mean, I'll have a go.
I hope that's what Gary was trying to suggest.
Gary can follow up with me afterwards. If I get it wrong, which I probably will. I mean, I think I would focus on chronic disease, to be honest. I mean, I think obesity is a, you know, it's a state. But I think that when we're trying to encourage people to change behaviour, one of the ways that we do that is help them to, one of the ways we've been really successful in tobacco control is helping people see a sort of doctor's eye view and have things become really tangible for people. So we've been testing different ideas with the sugary drink stuff and looking at warnings around disease states and what have you. But what we've actually found is the messages that are the absolute most concrete, which is not surprising actually, are the ones that are most powerful. So the ones that actually right now tell people exactly how much sugar is in a drink are the ones that make people stop and think. They can't sort of self-exempt from it because it's quite tangible. And so that probably is the option that's looking most promising at the moment. But that's what we do. We test the messages that are most effective and we look for impact as well as unintended consequence.
Caroline, I think they're going to let me clarify.
Excellent.
I think you've pretty much got it. I think that the obesity message is the one that's commonly used, and I don't think it resonates with policymakers or the public because it's so stigmatized.
Yeah.
And I just wonder whether there's an opportunity in the component of the work you do that involves messaging and talking to policymakers and liaising with NGOs to get people on the same playing field to shift the message away from obesity and onto chronic disease prevention. Because sugar par excellence is linked to cardiovascular disease, cerebrovascular disease, dementia, and the one that we forget about all the time, which is periodontal disease. Separate from the diabetes and all the other issues. And I think those are things that can be quantified in terms of cost and are not seen as stigmatized.
I think that's a good point, well made, Gary. I do worry a lot about the stigmatising around obesity because we don't stigmatise other diseases, and I don't think it helps anybody actually. And it also aligns with when we test the notion of obesity with people who, well, I think people probably of all weights, they actually think that it's something that they could see coming and they can readily modify if it happens to them, which I think is in fact not the case at all. So, well, yeah, good point, well made. Thanks, Gary.
Thank you.
Thanks, Gary, and thanks, Caroline. That actually brings us to a nice close this evening for the presentation. So I'd like to thank both Caroline and Tracy for excellent presentations and really giving us a really good idea of the type of research they're undertaking. Before we do close, I just want to remind people that these mini reviews are being recorded, and as soon as they're available, and they'll be soon to be available on the ABMC website. Please join us next week at the same time in the same BAT channel, where the presentation will be focusing on pharmacy, and we'll have presentations from Professor Libby Roughead and Clive Prestige, and this will be chaired by Susan Hillier. Again, thank you for joining us this afternoon, and have a lovely evening. Cheers.